Hello everyone, I am Dr. Beatrice Hippolyte and this is your world. Today we have the pleasure to have a great guest in the show. It's Dr. Mario Gustave. Good morning, Dr. Gustave. How are you doing today?
I'm doing fine. Good morning. First, I just want to take the time to thank you for that invitation because that's a topic that's means so much to me. And I think we're going to have some good time discussing neurocognitive disorders.
I'm looking forward to that. A brief description about Dr. Gustave's background. He is a board certified neuropsychiatrist
In general psychiatry,
in general psychiatry. Thank you. And he's a assistant professor of help me out
of psychiatry.
of psychiatry, and he's also an academy psychiatrist. Dr. Gustave, how long you been working in the field?
Let's say 24 years.
24 years.
Yeah.
Prior to that, were you a GYN doctor?
Yes, I come from the top down and then I go back to the top now.
Okay, so if I may ask, is there any reason why you switched from being a GYN doctor to a psychiatrist?
This is one word, opportunity.
Okay, so, opportunity. So, who's not really looking for better opportunity? So, it's like that's how we grow. It's like the more you can grow, the more you can reach to the higher or to the top, so the better. So, I understand that, and I guess everybody will kind of like relate
That's it.
to that answer. Today, we're gonna talk about neuropsychological issues.
Neurocognitive disorders. Once again, thank you so much. So, we're gonna discuss neurocognitive disorders today, but I'm thinking about it. Before we got the disorder, thing was okay. Something happened. So, we need to see how thing is normal first before to go to the disorders. Let's try to understand the brain first. It's a very specialized organ. We have a small unit in the brain, they call it a neuron. Let's see what happens in the neuron. Let's see normally how that neuron functions before to understand the disorders that may occur. Usually, we got that neuron doing nothing. So the way it works is under stimulation. The electricity in the neuron is gonna change. So when it's at rest, what is the level of electricity? We know is minus 70. Like I said, under stimulation, we're gonna change that electricity, sometimes make it positive, sometimes make it a little negative. So what happens when we make that neuron or we stimulate that neuron and it changes? We're gonna see a cascade of reaction. I don't think 1 hour, 2 hours will be enough to discuss the changes that will happen on the stimulation of that neuron. The first I have to tell you, there's a couple of electrolytes like sodium that will play a big role in that change, and we have chloride. But I have to say more. We're not gonna see those change just like that. You know how do we know there's change in the neuron? Because we can see change in behaviors. We know what those small little molecules are doing. I'm gonna give you a couple of them and explain what their job, what they are supposed to do. And you understand based on what I see, I can say, oh, I know what's going on. I know what is not working here. So, stay with me right there. We got one called dopamine. We got the acetylcholine. We got thousands of them. Let's stay on those two. And I'll give you an example right now so you can understand. I say everything got to be normal. When it's in excess or in deficit, we're gonna have behaviors changes. Example, if you have too much dopamine, you know what will happen? You may hear voices that can lead to psychosis. What about if you have not enough dopamine? You can have a common disease they call Parkinson disease. You see, let me repeat myself. Things got to be normal. Otherwise, excess or deficit gonna produce different type of behavior, different type of changes. So once again, we're not gonna see those changes in the brain, but when we see your behavior, we know what is not working. All right, I'm talking about Parkinson first. Let's understand something. I said deficit of dopamine will lead to Parkinson. Oh, if I know that, I can correct that. That will be easy. I'll just give you dopamine. We're not going to describe how we do it. It's a little complicated. But if I can give you dopamine, put it at the normal level, oh, look at that. The Parkinson's improve a little bit. So I know that was really a deficit in dopamine. But there's more than that. There's more disorders we can see. And based on, like I said again, the way you behave, I will know. Let's see, we got major neurocognitive disorder. We have mild neurocognitive disorder. Okay, let's see, major, mild. In major, we have mild, moderate, and severe. Understand with me, mild neurocognitive disorder is not the same thing than major neurocognitive disorder mild. There's a distinction, and I'm going to explain. The way I'm going to make that distinction will be the way you behave, the way you function. Let's say we got some activity of daily living, right? We got basic activity of daily living. We got instrumental activity of daily living. Let's see, people with mild neurocognitive disorder can have problem with IADL, instrumental activity of daily living. But the basic ADL will be okay. What are the basic ADL? Something like eating. That's very simple. It doesn't require too much skills. Just put a spoon in your mouth. What is IADL? Cooking. Oh, now that one is more difficult. You need to remember the sequence, when to put the water, when to turn on the stove, things like that. What, again, another basic activity of daily living?
Taking shower,
Taking shower, walking, switching from a chair to a bed.
combing your hair.
Yeah. What is instrumental activity of daily living? Paying your bills, making a phone call, manage your house. Those require more cognitive skills. So let me repeat what I said. If your basic activity of daily living are intact, but you have problems with your IADL, maybe it's just a mild neurocognitive disorder, right? But when you have problem in both IADL and basic ADL, that's a major neurocognitive disorder. In major neurocognitive disorder, we got many of them. Some books describe 13. They include so many of them. You told me somebody's coming to discuss Alzheimer's. So Alzheimer's will be one of them. So I'm not gonna discuss Alzheimer's because there's many other cognitive disorder that can be
Yeah,
discussed
we
here.
have Alzheimer, we have Parkinson, we have Huntington, we have amyotrophic lateral so
Sclerosis,
what we
Lou
normally
Gehrig
call
syndrome.
ALS.
Yeah,
So it's like you said, it's so many of them. But what are the most common ones?
Alzheimer's is 60 to 70% of all of them. is really high. Alzheimer's is 60 to 70% of all neurocognitive disorder. That's the most common one. And then after that, you got vascular neurocognitive disorder, Lewy body neurocognitive disorder, LBD or PDD, Parkinson's disease dementia. Those are two sisters. They have the same cause, but there are some differences maybe we can discuss later. So I was saying, so when I see your behavior, I may have an idea of what's going on. And what I'm gonna try to do is to correct, to put that neurotransmitter at baseline, and that could change and improve your symptoms. Other thing we talk about is like, what are the cognitive symptoms I'm talking about? Because according to the DSM-5, the book the psychiatrists use to make diagnosis of mental disorders, if you have one cognitive symptom, you diagnose with neurocognitive disorder. One symptom, that's neurocognitive disorder.
One symptom, can you be more specific? One symptoms of what?
I'm gonna tell you in a few seconds.
Okay.
So I said one symptom, that's neurocognitive disorder. Like you said, what are those symptoms? There's a few of them. Amnesia, problem with your memory. Aphasia, problem with language, communication. Apraxia, problem with fine motor movement, problem with neglect syndrome. I don't know if people heard about that. And we got agnosia, problem with recognition. We got people with neurocognitive disorder cannot recognize their own children. That's bad. That's really sad. That's a terrible disease, right?
It is.
Yeah.
It's most likely Alzheimer and dementia. Not
As
dementia, most likely Alzheimer.
Alzheimer is the most common type. Like I said, 60 to 70% of them will be Alzheimer's. Like I said, that's a terrible disease. It takes time. The onset is so slow compared to vascular neurocognitive disorder, where the onset is abrupt. You got a stroke, and tomorrow morning you have problems. That's really abrupt. And Alzheimer is insidious. It takes time to show. So sometimes people miss the diagnosis at the beginning. So we're talking about aphasia. I think I need to discuss that a little bit because I've seen that's one of the popular symptoms we see in neurocognitive disorder. What is aphasia? I said we have a problem with language. We have a lot of specialized structures on the brain that is responsible. They are responsible for our language. You have one in the frontal lobe, they call it Broca's, one in the back, in the temporal, and in parietal, they call it Wernicke. Let's see, the Broca's is responsible for the motor component of speech. Motor component of speech. So if I rupture, if I block the artery supplying Broca's, you're gonna see me having problems to express myself. That will be a non-fluent aphasia, because my problem is like I cannot express myself, but I can understand because I have no problem in the other area called Wernicke, who is responsible to understand what people are saying. If I have a problem in Wernicke, I can speak, but I can understand. Think about it. I can speak, but I don't understand what you're telling me. Guess what? I'm gonna talk gibberish because I don't understand. You ask me a question, I don't understand, but I can speak. I see you moving your mouth. I'm gonna speak, but I will not make any sense. So it's not pretty things to see people suffering from those diseases, like I was saying. Common thing, people need to make a distinction that's between those neurocognitive disorder and a delirium. A delirium is something that people need to think to make the diagnosis. You have to think about it. That's the patient who is good with no problem talking to a doctor, and when the next doctor comes, the patient is so disorganized, you're not gonna believe it. There's a change in that patient consciousness. That's now you're gonna say, this is not neurocognitive, this is not dementia, this one is delirium. The patient is not stable. He's okay at one time and really completely disorganized the next minute or the next hour. We always have to make that distinction. No, you remember I just told you one cognitive symptom is no cognitive disorder. Everybody should be able to do that, even my mother. So, when we're gonna need help, if to make that distinction, which type of neurocognitive disorder is that? You know, in order to do that, we need a very good history and we need the physical exam. I'm gonna give you a couple of examples so you can understand.
But before you even go any further, so is there an age of onset for each of them?
Uh, Usually, if I can say a word about Alzheimer, Alzheimer usually starts around 60 and double. The prevalence is 2% at 60 years of age, but double every 5 years, meaning the prevalence will be 4% at 70, 8% at 75, and then. So, yes, Alzheimer, the onset is usually around 60, but there's other type of neurocognitive disorder start a little early. Like Huntington usually is the 4 decade, around 40, 30 to 40. That's where we see the
That
onset.
early?
Yeah, for Huntington. But that's a genetic thing. You get it from family, from your dad most of the time. So, yes, that early. We got frontotemporal dementia is earlier than that Alzheimer's disease. So yeah, different ages. That should be part also of my assessment. That should be very. That should mean something for me. Of course, vascular dementia can be at any time. People have stroke almost at every time. So you remember I talked to you about agnosia, right? Difficulty to acknowledge, recognize even your children. That one is terrible. That's really terrible, I think. So you remember I was saying also we got those little molecules. They are very small on the brain. They are the one that will respond. If I wanna raise my hand, trust me, the order will come from my prefrontal cortex. My prefrontal cortex is gonna send the message to my premotor area and said he needs to move his hand. And then from there, he's gonna send it to the muscle. But remember, we have those small little molecules that will do the job after I change the electricity in the neuron. That's the way it works. That disease usually, many of them, the life expectancy will be around 10 years. To diagnose after diagnosis for Alzheimer, for many of them, with only one exception, and that exception, I need to talk about it. That's the one they call Creutzfeldt-Jakob disease, CJD, neurocognitive disorder, kill people between 6 months and 1 year. They call it also mad cow disease. That happened in England at one time. We have a big issue that was some time ago. That's the same prion. That's a small little molecule that infect people and give you a lot of problems. When I have the dementia, I told you the history is important, the physical exam is important, everything will be important for me to find out which type of the neurocognitive disorder, because the treatment will be different. I told you, if I have Parkinson's disease in dementia,
based on the diagnosis.
of course, I need to give dopamine to that patient. If I have Alzheimer's disease, dopamine will not help me. I need to have the acetylcholine level a little higher for that patient. You see, that's how important is the diagnosis of neurocognitive disorder. So how we make that diagnosis again? History. When was the first time you noticed that change? Yesterday? Oh, no. That's maybe vascular neurocognitive disorder. When the first time you noticed that, I've been saying, not doing well, but how long? Maybe 1 year? You sure? It could be 2. Because it's so insidious, people, it takes time to tell you. That time started maybe 3 to 4 years. So the history is very important. But the physical exam is important also. If you just...
the duration.
Definitely. If you have a stroke, it may be vascular disease. If you have a cardiac condition or disease, it may be vascular disease. If you are doing well, you decline very rapid, or I'm thinking about CJD, Creutzfeldt-Jakob disease. But I told you, Parkinson's disease dementia and Lewy body dementia, they are 2 sisters because they almost got the same cause. In the one they call Lewy body neurocognitive disorder, what you're gonna have is like vivid hallucination. And there's some things also that will happen. Only your partner can tell the doctor, oh man, it's been kicking me all night. They call it a REM slam behavior disorder. Because you see, when I sleep, I need to be paralyzed. Even if I have a dream playing soccer, you're not gonna see me moving my foot. But in that disease, I cannot control that. That's why I will kick my partner. That's why my partner will complain and sometimes sleep somewhere else.
So in that situation, body movement will be involuntarily?
Involuntary sleep.
Okay.
I know some people, when I use it, they say, no, I got Lewy body, because they want to kick people. No, don't use that as an excuse.
Because you don't want to deal with with any legal problems down the road.
Don't go kick your partner and say that Lewy body neurocognitive disorder, please. So there's that genetic component also. They find out. You see, there's a lot of risk factors. We can talk about a few of them. There's a big protein that the APP, amyloid precursor protein, through enzyme is gonna cut that protein. Sometimes they cut the protein wrong, give you an amyloid beta protein 42, who is not water soluble. You cannot eliminate that protein. Aggregate and kill the neuron. You remember the little molecule that make up the brain? So you can have also neurocognitive disorder because of that. There's also another risk factor, the ApoE, apolipoprotein, is just a cleaning coup from the brain. We remove the cholesterol, a clean thing. It comes, that one, in different flavors. There's one, ApoE4, ApoE3, ApoE2. If you have ApoE4, you get ApoE4 from mom, ApoE4 from dad, that will increase your risk to develop neurocognitive disorder. If you have ApoE3 from both parents, it's neutral. If you have ApoE2, that protects you against neurocognitive disorder. You're not gonna believe that. Maybe you need to check it yourself to find out what I'm saying. Can I tell you, one of those neurocognitive disorder is so expensive, America used maybe four times more money to address that neurocognitive disorder compared to cardiac condition.
Is there any specific one?
Alzheimer's, of course. Let me tell you, we got four. You have to follow that one with me. You have to help me on that one. We got 4 million cases of Alzheimer, right? How much money? $100 billion for 4 million of Alzheimer's. We got 56 million of cardiac condition.
So
How much money?
the amount that you just mentioned is being spent yearly.
Yes, yearly. 128 billion for 56. People need to help me with that arithmetic, right? Think about it. 56 million, only 128 billion. Only 4 billion, almost the same thing, 100 billion. That disease is very expensive. Think about, you need, some of them need 24 hours special service because they wander on the street. They are dangerous because they will leave the stove open. They will go out at night. Like I said, it's a lot of support, a lot of services for that disease.
For caretakers. So it's being considered
Yeah, of
in
course,
that.
everything is part
Okay,
of it. Of course, caretaker, nursing home, forget it.
that's a lot of money.
That's a lot of money. The distinction in vascular and Alzheimer is very easy. Usually, there's a scale you can use. You need to get the history. High blood pressure is something, cardiac condition is something, diabetes is something. Uh, the way the disease progress. Let me tell you, in Alzheimer, you got a very nice curve going down. In vascular, you got a stepwise progression. You got a stroke, the person decline, but plateau until the next stroke, decline, plateau again until the next stroke. So the distinction can be a little easy between vascular and Alzheimer. But you know what? Where we have problems sometimes is to make that distinction between frontotemporal dementia and Alzheimer. If you follow your patient, you're gonna have a little clue, because in frontotemporal dementia, they have no social graces. Those people, they curse, they disrobe in front of people, they are hypersexual, they have no boundaries. It look like a little mania, the way they behave dangerously. They don't
Very
care.
unpredictable.
No boundaries at all. I'm telling you, they will curse at you. Actually, let me tell you, I have to say something that happened to me. I was doing a group where I work, and I have my cup of tea on the table. The only patient we suspect to have frontotemporal dementia came up to the table, get my coffee, get a sip, and put the cup back. That's how much boundary. She doesn't care. She doesn't care. So, like I said, I don't wanna talk about Alzheimer like you're gonna, yeah. But I have to say just a couple of words. There's many hypotheses about that disease. We got a cholinergic hypothesis. That's the one, the most popular one they use. They use a lot of cholinesterase inhibitors. Remember I told you what you need to keep the acetylcholine level a little high.
Hi.
The way they're gonna do that, they not, acetylcholine, after doing its job, got to be neutralized, right? They block the enzyme that's supposed to do that. That's the cholinesterase. They use a cholinesterase inhibitor to block that. There's maybe 2 of them on the market right now. Rivastigmine, galantamine, donepezil. There's another one they don't use because it's too liver toxic. But they use also another drug, that's memantine. that block the excitotoxicity of the cells. We haven't discussed that because that will make that.
And I'm pretty sure so each of those medications have really serious side effect. So it's like let's say for example, so whatever the neuro condition issue that somebody may be dealing with, so it's like so if I'm taking this type of medication or that type of medication, is blood work for some of them are required.
Yes, I'm so glad you brought. I didn't want to discuss it. You're the one coming with it. You have to be responsible.
Because I know some of my patient or clients, so if I may call them that way, so it's like those who are taking lithium. Lithium is a very, the side effect of lithium, so it's like so can lead to kidney damage. So it's like those clients need to be monitored, like on a very very close, and blood work I think is required every 2 weeks or every month.
Not for those. The thing is, you remember what I said at the beginning? You need to increase the level of acetylcholine. So all we need to know, if I'm gonna increase the level, what acetylcholine can do to my body. That's what I need to know. That will be the side effect. What acetyl can do on my body? Let me think. Acetylcholine will put water everywhere on my body, increase salivation, increase urination, diarrhea. Everything that acetylcholine will be the side effect of those medications. What else acetylcholine can do? Let me see. On the heart, what acetylcholine can do on the heart? It will slow down the heart. That will be a side effect. So if the heart rate is too low, you don't give those meds. What else acetylcholine can do? Let me see. It can increase water everywhere. I said also in the lungs and constrict the bronchioles. If I have asthma, maybe I need to be careful with that medication. Like I said, the side effect is any type of effect that acetylcholine will have on my body.
But any doctor who's treating you for whatever condition that you may be dealing with will know
Oh,
about your medical
yeah,
condition
definitely, of
and
course,
pick on and from there will decide which medication will be more appropriate to prescribe you in that situation.
of course. There's no question about it. So, like I said, we try to go over, like I said, very superficial on those different type of neurocognitive disorder. For our first meeting, I hope we're gonna have more. I'm gonna invite myself. Meaning, think about it. Please, the earlier you address those issues, the better for your patient. A little memory problem, you forgetting your key. I was going back to my house, I get lost. I couldn't get there. Maybe that's the time you go to the doctor. Uh,
But how many times that have to happen? If that
cons-
only happened one time, so let me share an example. So it's like one time, so I was on the phone talking to somebody. So it's like literally I told the person, oh, give me 1 second, I have to go back home to get my phone. And the person was like, Beatrice, it's not the phone we are talking now. That's the phone you're using to talk to me now. And I'm like, oh, but that's only something that happened once.
I know people will be defensive about that. But one time doesn't mean anything at all. Maybe I was thinking about something else. Maybe I got some distraction. Maybe it's not important to me. I got something. But one time, a few times doesn't mean anything.
Okay.
And then, however, when you get in your 60s, in your 70s, you're gonna have some deficit. They are not disease. That's age related. You need to make adjustment for that. If somebody wanna send me to a market right now, I'm gonna have a piece of paper. Would you tell me what you want? I'm gonna write them. Maybe 30 years ago, I didn't need to do that. Maybe I could remember them. If I have to go to two places, I have to make some effort. It's not a disease because I can make adjustment. This is what we call age-related cognitive things.
Cognitive. Okay.
So, you know what? Maybe I'm gonna stop here if you have any questions. So,
Yeah, so thank you so much.
you're
That was
welcome.
really, really interesting. Of course, I do have questions.
Go ahead.
So I know today, so it's like it was not about medication, so we didn't really tap on what medication for each of them. Though you mentioned some medications, hopefully, like in the not too long, you will be coming back to talk about pharmacology.
Of course.
So now let's start with the first question. So what experience do you have working with patients with neurological problems?
I have the privilege and honor to did 2 years of research at Downstate Hospital with Dr. Carl Cohen, who passed not too long ago.
Oh,
That
sorry to
was a,
hear that.
that was a great guy. So I did research for 2 years. I think I have two presentation that was at Puerto Rico, if I remember, or San Diego on the study we were doing. And I think I wrote a paper also on neurocognitive disorder. So I got some experience at Downstate with neurocognitive disorder.
I know oftentimes medication is not something that people feel comfortable, and I don't want to say everybody, but most patients. So, and it's like whenever, even if it is high blood pressure medication, diabetes medication, whatever type of medication, or medication for people who suffer with mental health issues, people either, for the reason, either for the side effect related situation or whatever other personal reason, people tend not to take medication. Have you ever worked with patients, with neurological issues who, for whatever reason, don't want to follow the treatment or don't want to take medication?
As every other patient, they have problems. The people will stop medication when they have side effects. They will stop medication if we don't take time to explain, to make them aware of the possible side effects. So that's our job, to make that education, to prevent people, to make people act, to make like that balance between the benefits and problem with the side effects.
Okay, so education is vital.
Definitely.
Because so the more the people are being educated about the
Oh, the
condition,
side effect.
so it's like the more insight they're gonna develop into the situation, and down the road have the willingness to embrace the idea of taking medication,
Of course.
not only just taking medication but taking medication as prescribed.
Of course.
Dr. Gustave, so it's like, is there any treatment? What are the treatments that they have, for people who suffer with neurological issues?
As I said at the beginning, there's many of them. So that will be very difficult for me to go to each of them.
Okay.
But we got success with Parkinson's disease. The dopamine will give them slow down the process,
Okay.
and then that's why even with Alzheimer, we can slow down the disease for 2 years. We got some
Okay.
success.
Of that said, let's move on to the next question. How do you assess and diagnose neurological conditions?
Like, think about it when you see the person behavior, when you see the person physical condition, that tells you maybe what neurotransmitter is deficit or in excess. If you're psychotic, maybe you got too much dopamine. If you got movement disorder or Parkinson, maybe you lacking dopamine.
Oh.
The excess give you psychosis, deficits will give you Parkinson.
Okay. What treatment approaches do you find most effective for neurological issues?
You have to be a team approach because we need people, we need pharmacology, that's true. We need social interventions, that's also true. We need psychological intervention, that's also important. But we also need support in the community. Family play a big role. Family is so important. Not only to give you what happened. Sometimes we have patients who cannot tell us about the issue, about what happened. So family will play a
A major
significant
role.
role.
Okay. How do you stay current with advances in neurological research and treatment?
The thing is, I am helping people, especially the psych resident I interface, passing the board exam. So therefore, I have to be sure I'm talking about the current things with them.
Oh, okay. That's why you're constantly busy, working
Yeah,
almost 24/7.
definitely.
I know you are a busy man, and that's why, I really appreciate the fact that you were able to fit me in your schedule, or,
No problem.
to address that important issue with those who are listening or watching at this moment. My last question: can you discuss any challenges or successes you have experienced working with patients with neurological disorders?
Uh, that's always just, I take the last part. That's always a nice feeling when you see you can help people. That's so great when somebody coming with a deficit, you're able to improve or decrease the level of that deficit. The thing, sometimes we got some beliefs that not helping. People sometimes want to do things their way and will not talk to us about what they are doing, which is very dangerous. If one day I have the privilege to come back to talk about pharmacology, you will see how dangerous to see when people take those medications with no measures, with uh, so many of them on the over the counter, things like that, and we mix them with the one we prescribe. Bad thing happen sometimes. That also sad sometimes to find out what people can do by lack of education or communication with the caretaker.
Okay, so when you say, like, people who mix them prescribe medication with over-counter medication, so it's like it could be anything, like most likely drugs, like,
Believe it or not, people feel it's okay. They have a pain, they go over the counter, get some Tylenol. That's a benign medication. Listen, there's no such thing. Tylenol can be very dangerous. Actually, that's the number one cause of liver transplant due to medication usage. So I don't know where we got that idea that medication is so inoffensive. That's not true.
medication was not something for people to be careful about. I think, doses will not even be a concern. They will have just say, hey, go out there and just medicate
Of
yourself,
course.
So that's very important. But have you ever, dealt with any client who tend to mix their medication with alcohol or any type of other drugs?
All the time. Actually, one thing when we get where I work, they cannot smoke. Would you discharge that patient
When you
and
say smoke, like a
cigarettes?
cigarette or weed?
Cigarettes.
Okay.
When we discharge that patient, the first thing they will do at the gate is to get a pack of cigarettes. The thing is, the thing cigarettes will compete with some medication that we give that patient. Let's say the level, I just give number. Let's say the level of the medication is 10 in your body. You get that cigarettes. You think, the doctor thinks you got a level 10. In fact, you got maybe 3, 4. So the person sometimes they compensate and come back because of that cigarettes, believe it or not.
Okay, I guess that's the end of our show. So thank you so much, Dr. Gustave,
You're
for
welcome.
taking time, like I mentioned earlier, to be with us today. And so it was a pleasure having you.
Anytime.
And before we leave, we want to leave everybody with some hotlines numbers. Sometimes, people may be dealing with people who suffer with any of those neurological issues Dr. Gustave just mentioned and don't even know what to do. So I'll leave you with the National Institute of Neurological Disorder and Stroke hotline. The number is 1-800-352-9424. Once again, the number is 1-800-352-9424. And the other one is the Brain Injury Association of America. The number is 1-800-444-6443. One more time, 1-800-444-6443. It was a pleasure to be with you today. I'll see you next time.